Hello, thank you for watching this video presentation. My name is Toshitaka Hoppo. I'm a president of Japan Foregut Society, JFS. I have been working as a foregut surgeon to treat patients with foregut diseases such as gastroesophageal reflux disease, GERD, and laryngopharyngeal reflux disease, LPRD, in the last 15 plus years. Today, I'd like to talk about what we can do to improve the quality of life of patients with GERD and LPRD. Let me start to talk about the current situation in Japan and then what needs to be done. Gastroesophageal reflux disease GERD is defined as a condition which develops when the reflux of the stomach contents causes troublesome symptoms and/or complications. The term reflux esophagitis has been well known by everyone, but many people may misunderstand that reflux esophagitis is equal to GERD. But reflux esophagitis is one of many mucosal injuries caused by GERD. Also, heartburn and regurgitation are two common typical symptoms caused by GERD. In addition, the GERD can cause atypical symptoms including non-cardiac chest pain and ENT pulmonary symptoms such as chronic cough and hoarseness. These atypical symptoms could be caused by laryngopharyngeal reflux disease, LPRD, which may be a totally different entity from GERD. I really want to emphasize here that the reflux esophagitis is just one endoscopic finding caused by GERD, so the reflux esophagitis is not equal to GERD. Therefore, when esophagitis heals, it does not always indicate GERD heals. Here's the classification of GERD in Japan. If there is a mucosal injury, it's called reflux esophagitis. If not, it's called non-erosive reflux disease. In Japan, the incidence of GERD has rapidly increased since 1990. It is reported that reflux esophagitis was found in 2.5% of people who had the annual checkup in 1990, as opposed to 10% in 2000s. It is also reported that up to 37.6% of Japanese have GERD symptoms and 60% of them had non-erosive reflux disease. Surprisingly, these numbers are very compatible with the ones in USA, where up to 28% of Americans have GERD symptoms, 21 million are taking PPI, and the annual GERD related to medical expenses is greater than $10 billion. It is also well known that the quality of life of a patient with GERD is way worse than the one with congestive heart failure and angina. So it is important to treat the patient with GERD properly to improve their quality of life. As I mentioned earlier, there is a condition causing atypical reflux symptoms called laryngopharyngeal reflux disease, LPRD. LPRD is defined as a condition which develops when the reflux of the stomach contents causes troublesome symptoms and/or complications in ENT and pulmonary areas. We are not sure if LPRD is a part of GERD or if the LPRD is a totally different entity from GERD. But the LPRD is pretty common entity and can be found in 20% of adults in USA, although there is no data in terms of the prevalence of LPRD in Japan. Interestingly, the quality of life of a patient with LPRD is even worse than the one with gastroesophageal reflux disease. I listed specific characteristics of LPRD here. LPR events seems to occur primarily in upright position. We often see the patient who can sleep at night but start to cough crazy once they wake up. Patients with LPRD may not have typical reflux symptoms or any obvious findings suggestive of GERD, such as mucosal injury or hiatal hernia. They may not have abnormal acid exposure to the distal esophagus. Therefore, a conventional esophageal testing may not be able to identify the patient with LPRD. 40% of reflux in hypopharynx may be non-acid. The symptom correlation seems to be poor because of the hypersensitivity in the hypopharyngeal area. Previous study has shown that as few as 3 LPR events a week can cause severe laryngeal inflammation and injury. Since many patients with LPRD do not have typical reflux symptoms, not only patients but also physicians may not recognize their symptoms are related to reflux. Therefore, many patients with LPRD usually visit all the specialties, but nobody can make a correct diagnosis. Eventually, the patient becomes exhausted and depressed. Therefore, it is important that physicians can recognize LPRD and initiate appropriate steps to manage these patients better. Treatment options for GERD and LPRD include medical therapy, endoscopic therapy, and surgical therapy. Since esophageal testing is not always available in Japan, medical therapy with diet and lifestyle modification is usually initiated if GERD and LPRD is suspected. The figure on the right side shows the relationship between the severity of GERD and a PPI response. X-axis is the severity of GERD and y-axis indicates the number of the patient who has taken PPI in the United States. Once the patient starts to take PPIs, most of them feels better. However, as the severity is increased, approximately 30% of a patient is found to have persistent or recurrent symptoms even with the maximum dose with PPIs. These patients can be a good candidate for endoscopic or surgical therapy. However, not many physicians can understand the indication of endoscopic and surgical therapy. Also, the endoscopists and the surgeons need to be well educated and trained to minimize the postoperative complications and side effects. What is PPI doing for reflux? This figure shows the impact of PPI on the number of different types of reflux episodes. Left side is off PPI and the right side is on PPI. So as you can see, once the PPI was on, the number of acid reflux was decreased, while the number of weekly acid reflux was increased. As a result, there was no difference in the total number of reflux episodes. This result clearly indicates the PPI just to change the pH in the gastric contents. However, PPI never stopped reflux. Therefore, the PPI is a good medication to treat esophagitis and heartburn. However, the PPI may not really work to treat regurgitation or laryngeal symptoms, which are caused by actual fluid movement from stomach to the esophagus or hypopharynx. What if patients are refractory to PPI? In the case of a proven GERD, in which a diagnosis of GERD was already made based on the obvious findings indicative to GERD, such as severe esophagitis, you need to make sure the patient has been taking the appropriate dose of appropriate type of PPIs in the appropriate way. We usually recommend the PPI needs to be taken in 20 or 30 minutes before meal. It's also very important to rule out any diseases such as Zollinger-Ellison syndrome, which causes excessive acid production in the stomach. If patients continue to be refractory to PPI even after this evaluation, the patient's GERD may be too severe to manage medically. In the case of unproven GERD, it is really important to utilize esophageal physiology testing to see what's going on and try to make a correct diagnosis because there is a significant overlap between GERD and these conditions listed here. Please do not say easily he or she is crazy without doing esophageal physiology testing. Why and how reflux occurs. We think that anti-reflux barrier at the esophagogastric junction is a key structure to prevent gastroesophageal reflux. Anti-reflux barrier is primarily composed of two muscle structures, lower esophageal sphincter and the diaphragm. In addition to them, these structures also work together to preserve the integrity of anti-reflux barrier at the EGJ. However, continuously increased intra-abdominal pressure or aging could injure this structure, leading to the development of gastroesophageal reflux. In contrast, when the anatomical defect is surgically repaired, all gastroesophageal reflux can be completely stopped. Therefore, we are treating GERD as a surgeon's disease. Here, I want to show you some intraoperative pictures. The left side is a case of large paraesophageal hernia, and the right side is the case of severe GERD, in which the preoperative esophagram or upper endoscopy didn't show any evidence of hiatal hernia. So as you can see in the case of large paraesophageal hernia, hiatus was widely open and most of gastric fundus migrated into the chest. In contrast, in the case of no hiatal hernia, the entire stomach was located under the diaphragm. However, as you can see on the lower pictures, the hiatus was as widely open as the one of large paraesophageal hernia. As you know, the lower esophageal sphincter and the diaphragm needs to work together to prevent the gastroesophageal reflux. However, the hiatus was already open, causing the severe reflux. Do you think that you can fix this anatomical defect by medications? That's the reason why we think GERD is a surgeon's disease. GERD is a very common disease. However, a diagnosis of GERD is not straightforward. You may not notice this symptom could be related to GERD or LPRD. Clinical symptom is highly dependent on individual perception. Therefore, the clinical symptoms are very unreliable. Low sensitivity and the specificity of symptom-based diagnosis was reported. Half of GERD patients may have no typical reflux symptoms. It is well known that PPI has a placebo effect. Therefore, the PPI response is non-specific to make a diagnosis of GERD. Also, it's reported that 30% of patients who presented with heartburn did not have abnormal pH testing. This highly suggests the heartburn could be caused by something else besides GERD. As I mentioned earlier, there is a significant overlap between GERD and the functional GI disorders. Therefore, it's really important to utilize esophageal physiology testing to make a diagnosis. However, esophageal physiology testing is not always available in Japan, and we have difficult access to the esophageal testing at this point. To improve this situation, all of us need to recognize and understand GERD and LPRD, esophageal physiology testing, and all treatment options available based on the patient's severity and the treatment goals. Therefore, all the specialties need to work together to improve the quality of life of patients with GERD and LPRD. For this purpose, American Foie Gras Society (AFS) was established 5 years ago. European Foie Gras Society was established 3 years ago. This year, we will launch Japan Foie Gras Society (JFS), involving the top experts of GIs, surgeries, and ENTs in this country. Prior to JFS, we published the GERD textbook by Kimpo Do in the last July. After that, we founded Japan Society for GERD LPRD Network in the last September. In addition to JFS, we are planning to provide up-to-date information on the website. We would like to contribute to improvement in management of GERD and LPRD in Japan. The first meeting of JFS will be held at Kioi Forum on November 11th. The program has many interesting topics as listed here. One of our missions is to internationally collaborate with AFS and EFS. Dr. John Lipham, who is the first president of AFS, is coming to Tokyo to give us a talk. Also, we will have Dr. Schopman and Zehtner from EFS for virtual presentations. At the end of the meeting, we are planning to have a debate session to discuss 3 interesting cases. We will have all the top experts in the same room. I really hope everybody enjoys discussing and learning. We do not have any barriers between specialties as well as industries. JFS will provide a place where anyone can discuss and network, regardless of specialties or experience level without any hesitation. We really want to work together to send the message with Japanese wisdom to the world. Please visit our website if you are interested in our activity. What I talked about in this presentation is well written in this textbook we published last year. Please read it through if you want. Thank you for watching this video presentation. I really look forward to working with all of you. See you soon.